Thank you, Michael, and good afternoon, everyone. I'm delighted to moderate this session. I would like to thank all the participants for attending this year's RDRC and staying with us to this last but not least session. We have three very interesting papers that complement each other really well with a common theme of the mitigating effects that health insurance, housing, wealth, and drug innovation have on the impact of health shocks on different outcomes. The first paper will be presented by Eric French of University of College London, who will discuss their work on the impact of medical spending shocks on wealth and insurance purchases among older Americans. The second paper will be presented by Stephanie Moulton of the Ohio State University, who will discuss their findings on whether home equity borrowing alleviates the impact of health shocks on health outcomes. And the third paper will be presented by Frank Lichtenberg of Columbia University, who will discuss the findings on the impact of drug innovation on the receipt of Soci Security programs and use of medical care. I'll remind participants to put their question into the Q&A. And without further ado, Eric, take it away.
Thank you very much. Again, thank you very much, Irina, to the Social Security Administration and the organizers of this conference for allowing me to present some new facts on the distribution and dynamics of medical expenditure amongst the elderly. We're working on developing a model that can also be used to think about behavioral responses, such as in purchases of insurance. Although for right now, just in terms of what we're going to be focusing in on, is just how much medical expense risk do households face, both in a given year, as well as over their remaining lifetimes. The reason for this, that we think this is important, is that rising healthcare costs are a key financial issue. Some surveys suggest that this is the key financial issue that relatively affluent Americans are concerned about. Furthermore, given some of the proposed reforms to both the Medicare and also the Medicaid systems, we're interested in better understanding how Medicare and Medicaid reduce this risk. In particular, what we do is we first estimate a cutting-edge model of medical spending dynamics, and then we estimate the medical spending budget sets. So this way we can think about what share of total medical expenditure is paid out of pocket relative to the share paid by either Medicare or Medicaid. In terms of the data that we have health and retirement study data, which has good information on out-of-pocket medical spending, and we've been able to link that HRS survey data to both Medicaid and Medicare claims records. So we have good information in terms of medical care that's paid for either out of pocket by Medicaid or Medicare. We're working on imputing other payers right now. Now, given that we have good information on these particular payers, and these are the key payers for the 65 and older population, we focus in on this medical spending risk faced by those 65 and older. Let me show you a few facts. The first fact that I want to show you is that medical spending is concentrated. What you can see here is that on average, medical spending at the household level amongst those who are 65 and older is $14,500. So that's essentially how many medical bills are being generated. So this includes both Medicare, Medicaid, as well as out-of-pocket pays, but doesn't include insurance payments. What you can see is that, again, medical spending is quite concentrated. Amongst the top 5% of all spenders, they constitute 36% of total medical bills. Amongst the bottom half of all medical spenders, they represent only about 5% of all medical spending. The second thing that I want you to have a look at is who actually pays for this medical care. On average, about 20% of all this medical care is paid for out of pocket in the way of co-pays, nursing home stays, things like that. The main payer is Medicare. However, the shares paid aren't constant throughout the spending distribution. What you can see here is that amongst the top 5% of all spenders, about 16% is paid for out of pocket. But if you look at the bottom of all medical spenders, it's closer to 44%. So this should intuitively make sense. Medicare pays for a very high share of, for example, hospital stays. Medicaid often contributes for those who wind up in nursing homes for extended periods, whereas for relatively low spenders who are just really spending their money on, for example, eyeglasses, dental visits, Medicare contributes relatively less to that type of care. So at some level, we should be happy that we see this particular pattern, that Medicare and Medicaid cover a higher share of the highest medical expenditures. So back in the 1960s, Ken Arrow made the great point that a good insurance program should be covering catastrophic risk, not just day-to-day expenditures. And we see a little bit of evidence for this just in this cross-section of data. But of course, we care not just about medical spending in a particular year, we also care about medical spending over the course of one's entire lifetime or a household's entire lifetime. So in order to think about this, we devised a model of medical spending. Medical spending is going to be a function of three components. The first component of medical spending at the household level is just going to be a function of the health status and age of each household member. And then that captures some of the variation in medical expenditures, but most of the variation in medical expenditures that we observe really aren't captured by these observables. So we want a rich and realistic model of this unobserved component of medical spending, something that we can observe, but we can't explain using, for example, observed measures of health and age and the like. So what we do in particular is we estimate for this persistent component and the transitory component, we develop and estimate sophisticated models to think about both the distribution of these expenses as well as the dynamics. So in past work, I've estimated models of medical spending where, for example, medical spending is assumed to be, for example, normally or log normally distributed, but we want to back away from these functional form assumptions so we can realistically measure the entire distribution of medical spending, including the catastrophic risk of medical spending in a given year. In addition to that, we also want to measure the persistence of medical spending in a very realistic way. In order for us to do that, we're going to have this very flexible Markov model that allows for what is often referred to as nonlinear persistence. Now, in addition, for the health and survival, we'll estimate those using age, gender, marital status, and income-specific Markov chains. So what we can do with both our model of medical spending as well as our model of health and survival dynamics is we can simulate lifetime histories of health mortality shocks. We can also simulate histories of medical spending shocks conditional on health. And we can use that to calculate medical spending histories. So that's really what this is really all about, is trying to estimate both these medical spending histories, and then we can run that through our budget calculations, where we figure out the share that's paid out of pocket relative to total, and we can compute out-of-pocket medical spending histories. This shows what happens when we just simulate lifetime histories of survival. And we do this conditional on marital status, gender, health status, and also income. What I want you to take away from this is that there's a lot of variation that's explainable by what's going on for particular households or particular individuals at age 70. So what this is that a man in a nursing home, on average, he doesn't live very long, whereas a relatively healthy woman who's at the 90th percentile of the income distribution, she lives on average over 17 years. Furthermore, it's not just important for us to know what happens in terms of life expectancy of a given individual. We also want to know within couples how long the oldest survivor winds up living. On average, the oldest survivor within a couple lasts about 17.9 years. Furthermore, in terms of thinking about the probability of being in a nursing home, the key predictors of being in a nursing home in any particular year are both age and whether or not you're married. As a result, men are relatively unlikely to have a long nursing home stay at any particular point in their lives. Men typically die off before they're old enough to develop severe mental issues and the like cognitive issues, which often land them into nursing homes. Those men typically die first, leaving the women to wind up with these cognitive issues in old age on their own, and thus winding up in a nursing home. I'll skip the details of this work that we're doing in terms of the persistence of medical spending. The only key thing that I want you to take from this particular graph is that persistence is not a constant throughout the distribution. Lots of forecasting models historically have assumed that there's a lot that essentially persistence is constant throughout the distribution. So that's what you would get, for example, if your forecasting model was an AR1, for example. But what you can really see is that the key risk, it's not just high medical spending in a given year, it's this risk that you have at some level modest medical spending in a given year, but that medical spending continues on with you for a very long period of time. So just in summary, what we can again do is we can run all this through our different models or budget calculators. And what we can do is we can calculate what happens to medical spending over the course of people's lifetimes. This line right here, this bottom green solid line, shows mean medical spending for those who are single at age 70. On average, their medical spending is about $60,000, again, coming from copays and things like that. Sometimes winding up in nursing homes that may not be covered at all through Medicaid or Medicare. What you can see at older ages is actually medical spending, expected medical spending over the remainder of your life. It actually does not fall at all until extremely old ages. What's going on here? As you get older, of course, you're getting closer to your own death, and that reduces medical spending over the remainder of your lifetime. But every additional year of your life, that means that your expected longevity is greater. Of course, anyone who's age 90, their life expectancy is still several years. Those remaining final years are often extremely expensive in the way of medical spending. And so for that reason, medical expense risk over the course of your life, it's only resolved extremely slowly. And of course, here we have things for couples and also different percentiles of the lifetime medical spending distribution. So that's what I wanted to share with you today. We showed some facts about medical spending, both in terms of its dispersion, its persistence, the fact that a key driver of medical spending risk, it's not just the risk of catastrophic medical spending in a given year, but it's also that risk that medical spending is modest, perhaps because of cognitive decline or something like that, or mental health issues, but those problems that happen to last for the remainder of an individual's life. And then finally, we're working on a framework where we can actually think about how these risks will be mitigated both through the Medicare and also the Medicaid systems. Thank you very much.
Thank you, Eric, and we'll turn to Stefan.
All right, great. Can everybody see the screen okay?
Yes, we can see it.
Excellent. Okay, so thank you for having us here today. I'm excited to share some research that we're working on. The second to last presenter of the day on a Friday. So this is co-authored work with Joshua Joseph, Cecilia Leubel, and Donald Harron at OSU. And we're looking at health shocks. So we're building kind of on what Eric French is doing, where he's showing these health expenditures that are large in older age. And we're looking at how home equity might mitigate some of the consequences of these health shocks for individuals. And of course, the disclaimers apply. We thank the Social Security Administration for the generous funding of the project. So the economic security of Social Security beneficiaries is a really important topic. And one of the things that we've talked about a lot in some of our research and others here at the RDRC have focused on housing wealth as a substantial source of wealth for older adults. So particularly for those who are Social Security beneficiaries, SSDI beneficiaries, homeownership rates are still high among that population, and housing equity makes up a large portion of their wealth. So just for example, in 2016, nearly 1 in 5 homeowners age 62 and older had less than $10,000 in financial assets, but held $40,000 or more in home equity. But you have to be able to consume that equity in order for it to be able to help buffer expenditures. And so there's a literature that looks at how housing wealth, health shocks, and economic security generally. And there's a suggestion theoretically that this home equity may serve as a precautionary savings to help buffer the negative consequences of a health shock. And actually, Jim Paderba has done a lot of great work in that area. And they look at of this potential role of home equity theoretically. But it actually has to be converted to a liquid form if you're going to be able to directly pay for health costs that are associated with a health shock out of home equity. And so there's kind of this conceptual model I've drawn out here at the bottom. And there's 2 bodies of literature that exist right now. One is the green body of literature, one is the red body of literature. The red body of literature looks at the relationship between a health shock and reduced home equity. And so there's research that documents a significant decline in housing wealth after a health shock. So building on Paterba and Vinti, saying that often people don't accumulate their housing wealth until after there's some kind of an expense shock. They also show that these health shocks, whether heart attack, lung disease, and stroke, are associated with a significant decline in the wave right after that shock in a 2-year period in home equity after that diagnosis of a disease. Dalton Lefebvre go even further, and they show that an increase in ADLs, difficulty with daily living, are associated with a $12,000 decline in home equity for married couples. And actually they show that home equity ends up being the primary source of change in wealth following a health shock. And then there's this literature in the green. And the literature in the green tries to estimate a causal relationship between having home equity and health outcomes. And so the red literature is not really tying it to health outcomes. They're just saying that people are spending from home equity after a health shock or home equity is going down. The green is trying to look at the relationship between home equity and health outcomes. Hamadi and Dowd are 2 that they've done a couple of studies in this area, and they look at changes in house values, exogenous changes in house values, and how that associates with future health outcomes. And they look at problems with ADLs going down as house values increase, improved lung capacity as housing values increase, lower blood pressure. Lots of questions about the causal mechanisms here, but in general, they say that there's higher changes in house value associated with these positive health outcomes. Angrasani and Lee have a more recent paper where they look at changes in the house price indices around the Great Recession. And they find that areas that had a decrease in HPI were associated with the increased probability of hypertension. So they were primarily focusing on blood pressure. So this could be stress induced, but it could also be not being able to pay for medications. They don't look at the mechanisms again, but they find using self-report and biomarker data, this increase in hypertension in areas that had decreases in house prices. So our primary research question is to understand the extent to which home equity can help mitigate the economic burden created by a health shock, which might ultimately lead to better health outcomes. So we want to connect the dots there in that conceptual framework I presented. So first, we want to identify kind of the reduced form model, what the relationship is between home equity held prior to the onset of a disease might improve a household's ability to manage a health shock. And we're going to look at whether a disease that they're diagnosed with is adequately controlled in the periods after a health shock. And then we want to dig deeper into that causal relationship to try to understand if actually liquidating home equity through borrowing or home sale is a mechanism through which this might flow. So then we look at treating borrowing as endogenous, borrowing from home equity, the relationship between borrowing and subsequently the ability to manage those same diseases. So we're going to use the health and retirement study from 1998 to 2016. We're going to focus on people that had a health shock between 2002 and 2014. And we define a health shock similar to others in the RDRC have done this before, Katurba, one of them looking at the onset of a new disease between survey waves. So this is a person newly reporting that they've been diagnosed since the last survey wave with diabetes, heart disease, cancer, or lung disease. We pick these 4 diseases because they are 4 of the more costly diseases and more common diseases, and also because we can use biomarkers to measure some of the outcomes associated with these diseases. We're going to limit our sample to people who have biomarker data, which I'm going to explain here in a minute. And then we also trim outliers on financial variables, and we limit it to people that were homeowners in the wave prior to the health shock. They do not have to remain homeowners. We actually look at selling your home as one mechanism of liquidating your equity, but they have to be homeowners in the wave prior to being diagnosed with the disease. So of the 25,000-ish homeowners in our sample during this time period, 9,000 had a health shock between 2002 and 2014. And of these, we have biomarker data post the shock for about 4,077 of those individuals. And that's going to be our primary regression sample. And we're going to also break this out by the age that the person was when they were diagnosed with the shock. Our main interest is in people who were 65 and older at the time of the health shock. Primarily because we want to hold constant things like eligibility for Medicare, like Eric French just talked about, that we know is going to really affect your out-of-pocket expenditures. And then also B, because we know this is a really important population, particularly for Social Security, and this is where a lot of folks have a lot of their wealth in their homes. So if we look just at that over 65 population, we see that the primary health shock that they have in this period is a heart disease. 41% of our sample, 28% have diabetes, 21% cancer, and 15% lung disease. And we take the diagnosis of the first disease that we see in this time period, and we follow that disease as our focal outcome. If you're diagnosed with more than one disease at the exact same point in time, we're going to follow both of those diseases. And so we're going to use the biomarker data. And for many of you may be familiar with this already. It's in the health and retirement study. It's collected every 4 years, half of the sample each time. So for example, it started in 2006. One cohort, half of the HRS sample had their biomarker data collected in 2006, then again in 2010, and then again in 2012. The other half started getting collected in 8, and then had it again in 12, and had it again in 16. And so we're going to use that biomarker data to define whether or not, based on the disease you were diagnosed with, whether or not you were considered being uncontrolled on that disease. And actually one of our co-authors is medical doctor Joshua Joseph, helped us come up with these thresholds. So I'm not going to go into a lot of detail about the thresholds, but please feel free to ask if you have questions. But these were justified in the literature thresholds that are commonly used to identify a disease that's uncontrolled. And then just to kind of give you some descriptive statistics, the far right column is going to show you the percent of the people that are uncontrolled in the periods post being diagnosed with the disease in our sample. And so you can see, 37% of the people with heart disease are uncontrolled at some point in our post period, 33% with lung disease, 22% with diabetes, and 20% with cancer. So these are our indicators for being uncontrolled. We also use self-reported health actually as kind of an alternative way to measure somebody's health following a disease, very different than disease-specific biomarkers. It's not disease-specific, and it's self-reported. But we might find something different here. So we wanted to look at that as well. All right. So just to give you a sense of what happens, oops, I skipped this one. This is the change in health outcomes relative to the period of the shock. So I'm omitting period 0. This is the period when somebody is diagnosed with the shock. And that's when most people are going to have a spike in having a disease uncontrolled. That's the period that they're diagnosed. So what you can see is that the proportion uncontrolled, there's really not a statistically significant difference in the time trend of being uncontrolled after disease. Relatively, there's a lot of heterogeneity in our sample between waves 1 and 5 post-diagnosis. With self-reported health, probably maybe not surprisingly, people report or feel better, actually. So there's a significant increase in self-reported health. and the first 2 waves after being diagnosed with the disease. Maybe you feel really bad when you're first diagnosed and it gets a little better, but the biomarkers, again, aren't showing that this is a significant difference. So again, this kind of highlights the fact that these biomarkers and self-rated health are really measuring different things. I'm not going to spend a lot of time on this, but there's 2 facts I want to share here. These are kind of stylistic facts. Drawing on Eric's findings about health expenditures, you do see an increase in out-of-pocket expenditures in the wave of a health shock that persists in our data for at least 1 to 2 waves after the health shock. So you have this spike in out-of-pocket expenditures, that's prescription drugs, it's also total out-of-pocket expenditures, but you see that wages are flat, which isn't unexpected. These are individuals who are over 65 and older, and I'm looking at earnings here. Social Security benefits don't adjust based on having a health shock. So we're looking at earnings, which are the part that you might adjust, and it's flat. You don't see a change. People aren't offsetting the increase in expenditures with an increase in earnings. So this then asks, well, where are they spending it from? How are they paying for these additional expenditures? So stylistically, again, descriptively, we do see an increase in debt. So the gray line is non-housing debt levels in the waves after being diagnosed with a disease. The red and blue lines are the change in financial assets and home equity after being diagnosed with the disease. And so you can see that those are declining after the diagnosis. And so what we want to do is we want to measure not just home equity and health, we actually want to measure borrowing. And so in the HRS, we are going to look at an increase in your mortgage amount between 2 waves. And happy to talk to you about how we do that. We look at all different types of mortgages on all of your homes that you own. We also separated it by primary and secondary residence as robustness tests. In order to say you borrow, we have to see that you didn't move between waves. Otherwise, we're going to put you in our next category, which is the home sale. So if you don't move between waves and you have an increase in your mortgage, then we're going to say that you've borrowed an amount of money. Alternatively, if you move between waves and you sell your home, and we look at both first and secondary residences, we're going to capture the amount that you have home sale. Just to give you a flavor, of those over the age of 65, in our sample, about 11% are going to borrow over a 2-year period. So it's not insubstantial. And this is among our health shock group. So among people with a health shock, about 11% have an increase in their mortgage over a 2-year period. About 3% have a home sale in that same 2-year period. We're going to instrument for this borrowing and home sale equity extraction using a few different instruments. So one is the exogenous change in house prices. So we're going to use the house price indices lagged for an individual based on their specific zip code. We're going to also use the lagged zip code level house price. And then we're going to use an indicator for being borrowing constrained that strictly turns on if you cross a threshold that's often in the literature used to approve somebody for a mortgage, which is the 80% LTV threshold. So our methods, first, we're going to do a reduced form model, and we're going to use OLS, it's panel data model. We're going to use random effects. We're going to cluster our errors in the household, and we're going to look at whether or not home equity that you hold prior to being diagnosed with a disease, time invariant home equity prior to being diagnosed with a disease, is associated with that disease being controlled later on. The second model, we're going to have some more time varying effects, and we're going to see whether borrowing your mortgage, which we measure in the ways I just described, if that endogenous borrowing is associated with this disease being controlled. And we're going to measure that as endogenous using the instruments I mentioned before. So getting to our findings, reduced form, we do not find a significant relationship between home equity held prior to a diagnosis and being uncontrolled on your disease for either the older population or the younger population. However, we do find that it makes you happier. So you're self-reported, or you think that you're healthier. Your self-reported health is generally better among those who are diagnosed with a disease if they had higher levels of home equity prior to the disease. Then we're going to look at our regression results treating it as endogenous. And here we find that borrowing, so the mechanism borrowing actually is associated with a significant reduction in being uncontrolled for older adults. So those that are age 65 and older who borrow, about a $10,000 increase in borrowing is associated with a 7.8 percentage point decrease in the probability of being uncontrolled. We do not find a significant relationship between borrowing and self-rated health for those older adults. Although it is at the 10% level, it's marginally significant, so it's in the right direction, you're happier. but the uncontrolled is stronger here. So just to get to overall discussion policy implications, obviously health shocks in older age can be a significant source of financial insecurity, particularly for Social Security beneficiaries and those with lower income. Home equity is a large source of wealth for many of these older adults that may be used to help buffer these expenses, but you got to convert it to a liquid form. In fact, we observed that reduced form home equity held before shock is not significantly associated by itself with uncontrolled or controlled biomarkers. Again, about $10,000 borrowed lowers the probability of uncontrolled by about 23%, which was 7.8 percentage points. And so from a policy perspective, something that we've been doing a lot of work in simulations trying to think about, how could we relax these borrowing constraints that keep people from borrowing? So in our first stage model, you do see borrowing constraints are significant predictors of ability to borrow to ensure that people have access to their home equity after a health shock. And that might increase the financial security of Social Security beneficiaries, thereby improving their health outcomes, but also reducing longer term health costs. Thanks.
Thank you, Stephanie. And now we'll move to the next speaker. Frank, take it away.
Okay, thank you. So because I am last, I wanted to get a very snappy title. And so this is the title that I came up with. The objective of my study is to analyze the overall impact that biopharmaceutical innovation has had on disability, Social Security recipiency, and the use of medical services of US community residents during the period 1998 to 2015. Most of the data come from a wonderful survey called the Medical Expenditure Panel Survey, where the Agency for Healthcare Research and Quality interviews 25,000 people a year, gets extremely detailed information about their medical conditions, their health, their use of medical services, and so on. And the approach is to the effect of biopharmaceutical innovation is identified by differences across over 200 medical conditions in the growth and the number of lagged number of drug classes ever approved. I will illustrate that in a minute. This is only really measuring biopharmaceutical innovation, not other kinds of medical innovation like devices and so on. But the vast majority of private US biomedical spending is done by biopharmaceutical companies. And I am looking at new classes of drugs rather than new drugs. And the FDA says that essentially 70% of first-in-class drugs are priority review drugs. They offer a significant improvement relative to existing therapies. Now, to illustrate the, here's the overall research design. From the Medical Expenditure Panel Survey, we have a very rich set of indicators of both person-level disability and Social Security recipiency, such as whether the person receives any Social Security income, SSI, whether the person says they are unable to work, whether that person says they have cognitive limitations, and so on. We also have several measures, condition-specific measures of disability, like did you spend any days in bed because you have diabetes or asthma, and so on. And we have condition-specific data on the use of medical care, such as whether the person was hospitalized for a particular medical condition. So I'm looking at all of those measures of disability, et cetera. And the key explanatory variable is pharmaceutical innovation, the lagged number of drug classes ever approved for a medical condition. I am going to control for single year of age, single year of education, the number of medical conditions the person has, the prevalence of the condition, medical condition fixed effects, and year fixed effects. So, you know, theoretically, we're saying if there's like a 50-year-old person with a certain medical condition, with a certain amount of education, what's the probability that that person is collecting Social Security, is unable to work, and so on. Now, I do say it's the lag number of drug classes because, and here this illustrates the heterogeneity. So I have data on over 200 medical conditions, but here are 12 medical conditions or diseases where, and this shows the growth between 1995 and 2015 in the number of drug classes ever approved by the FDA for that disease. And we see that for one disease, diabetes without complication, there were 10 new classes of drugs over a 20-year period. Whereas for another disease, there were 0 new drugs. So there are high innovation diseases and low innovation diseases. And my hypothesis is essentially that we should see greater reductions in disability for diseases where there's been greater amounts of innovation. But there is a lag, because even though a drug is approved, the data indicate that it takes about 9 or 10 years for a drug to reach sort of peak utilization. So I would expect that if a drug is launched this year or a new drug class is launched this year, it's likely to take a number of years, like maybe 9 or 10 years, for it to have its peak effect on disability. So I'm able to test for that. Here are some descriptive statistics. It's a very large sample. So we have data on about 1.6 million medical conditions during the period 1997 to 2015. And we know sort of the average level of disability associated with each condition, the use of medical care associated with each condition, and so on, as well as demographic information. This illustrates the 20 most prevalent conditions, hypertension being number 1. An estimated 71 million Americans had hypertension in 2015, and so on. So that illustrates the disease classification. I do control for prevalence because one could worry that, for example, if there is increased awareness about a disease, then people with relatively less severe cases will report that they have it. That would affect the mean disability. So I do want to control, and I do control for prevalence. I also suppose that now many people in the survey have multiple medical conditions. Suppose that person A has a single medical condition like diabetes, whereas person B has diabetes and 4 other medical conditions. Well, if there is innovation related to diabetes, I hypothesize that will have a greater impact on the overall person level health of a person that only has diabetes than it will on the person with 5 medical conditions. So I also test for that effect. Well, in my brief moment of fame, here are my key findings. That the estimates in fact indicate that the probability of disability, Social Security recipiency, and medical care utilization is inversely related to the number of drug classes previously approved. And the length of the estimated lag is generally 6 to 9 years. So how disabled a person is depends on how many drug classes were approved up until 6 to 9 years ago. And that is not surprising given the gradual diffusion of new drug classes. And due to this lag, the number of current drug class approvals may be useful predictors of future disability. That is, if you want to know how many people are going to be disabled because they have diabetes 9 years from now, well, we already have some prior knowledge of that due to the lag. I also do find that basically if someone has a smaller number of conditions, then they would benefit more, their health would be improved more by medical innovation for their condition. Well, let me give you an idea of the magnitude of the effects that I find. Well, this illustrates kind of what the lag structure looks like. And let's say we focus on the right-hand side. Let's say we look at this is looking at the probability, and I'm estimating probit models, that a person received SSI in a year, and how that is related to the number of drug classes for that person's condition 0 to 15 years before. And what I find is that the probability that a person with less than 5 medical conditions received SSI was significantly inversely related to the number of drug classes used to treat that person's medical conditions launched 0 to 15 years earlier. That is, it's significant at every lag, but it was most strongly related to the number of drug classes used to treat the person's medical condition launched 12 years earlier. So, and that is consistent with the diffusion data. So this is the probability of receiving SSI. If we look at the probability of receiving Social Security, there's no contemporaneous effect, that's insignificant, but the most significant effect is with a lag of 12 years. So that's the effect on Social Security. So essentially the liabilities of the Social Security system do appear to depend on biopharmaceutical innovation with a lag. And here are several other indicators that one is, what's the probability that somebody spent days in bed for a condition? The probability that they had any inpatient hospital stays for the condition, and the probability that they had any home health events associated with that condition. And those are all significantly inversely related to the number of drug classes that had been approved up until 12 years before, for example. So, and so in terms of the magnitude, the estimated reductions in disability, et cetera, resulted from previous innovation. The estimates indicate that the number of people who were completely unable to work at a job, do housework, or go to school in 2015 was that was reduced by about 4.5% by about 20 years of innovation. So we have 20 years of innovation, and that reduced that probability by 4.5%. It reduced the number of people with cognitive limitations by about 3%. And even though there were like no Alzheimer's drugs approved by the FDA, the literature shows that if you have certain comorbidities like depression and high blood pressure, that you are at greater risk of having cognitive limitations. So that may be a side effect, a positive side effect of innovation for other diseases. The estimates also indicate that the number of people receiving SSI was reduced by about 250,000. The number of people receiving Social Security was reduced by about 1 million, or 2%. And there were also significant reductions in the number of home health visits and the number of inpatient events. Now, if I try to place a value, say, well, what's the value of those benefits? So this table shows the estimated value in 2015 of some of the reductions in disability, et cetera, resulting from previous innovation. So for example, the number of people who were unable to work was reduced by 3.9%. And given the average wage of American workers, about $1,000 a week, that would be worth about $27 billion. That if you could enable you could eliminate that, that would be worth $27 billion. The reduction in Social Security, about $14 billion. But by far the largest benefit is the reduction in hospital care of about $56 billion. And I've shown that in other studies of the US and other countries. So if we add up the value of a number of benefits, and this is only a complete list, then we get the value of about $115 billion. That's the value of the innovation. And that turns out to be fairly close to the expenditure on these new drug classes, slightly lower, about $127 billion. But for a number of reasons, the costs are likely to be lower and the benefits are likely to be larger than these figures. For example, I'm completely ignoring the benefits of increased longevity, which I think are probably much larger. Thank you very much.
Thank you, Frank, and thank you everyone for the great presentation, and we'll turn to questions. Okay. The first question is for Stephanie. For a homeowner with home equity who is spending well beyond their means, doesn't tapping home equity put them at serious risk of losing their home if they don't resolve their spending problem, which may then put their health at further risk? Stephanie?
Yeah, sure. No, that's a really great question. So, I mean, I think there's two things that could put them at risk. One is if they take out a lot of debt on their home and they can't afford the monthly payment. And if they can't afford that monthly payment because they already have a strained budget, then they could, be at risk of either needing to sell the home or face foreclosure. They likely wouldn't face foreclosure if they have a high loan to value ratio. So it's kind of this combination of, but they might be forced to sell their home. And so different tools. So a home equity line of credit, for example, often has a very small monthly payment for the first 10 years. And then after that, there's and actually they pay an interest only portion for 10 years and then it's amortized over 30 years. So for like borrowing $30,000, the payment's about $200 a month, for example. So for some people that might be affordable, for some it might not. Another option is something like a reverse mortgage, which we've done a bit of research on, where there you actually have no monthly payment, but you end up in a situation where your balance on your mortgage is growing over time. So it really depends on kind of how long you plan to stay in the home, whether that's the right option for you. But that would alleviate the budget constraint for a person who is already, at a budget constraint and wasn't able to pay a monthly payment on the mortgage. But it's an excellent point and something that's important to think about, kind of the housing cost aspect of it, combined with the kind of liquidity that you get for it. And actually, Chris Herbert at Harvard is doing a paper for RDRC right now. One of the complementary papers is looking at monthly housing costs and health outcomes.
Okay, thank you, Stephanie. And the next question is for Eric. If I understand correctly, medical spending is especially persistent for the population in the top spending group. Do you know those persistent medical spending are mainly for Medicare, given 70% of spending are for Medicare, or Medicaid, nursing home?
Right. This is a great question that gets to the heart of what an optimal social insurance scheme should look like. So not only should social insurance schemes potentially insure high medical expense in a given year, but those who face modest but high medical spending in multiple years. In terms of what we've done so far, we've looked at the share insured by Medicare and Medicaid for a given year. And Medicare and Medicaid do insure a higher share of total medical spending amongst the highest spenders in a given year, but we actually have not looked over multiple years, but that would be really interesting to have a look at. Thank
you, Eric. The next question also for Stephanie. How does the 11% cash out and 3% house sales for those with health shock compare to the rates for those without health shocks in the general population?
Yeah, that's a very good question. It's slightly higher. Another way to ask this question is, does the rate of borrowing or home sale increase after the health shock? So we actually did some trend graphs to see how does that change, just in general, the rate of borrowing and home sale change after a health shock. You see that the rate of home sale increases significantly after a health shock, particularly as you get to 2 to 3 waves out from the health shock. The rate of borrowing actually doesn't change that much. So prior to the health shock to after the health shock, about 11% per year is about what we see in the population of 65 and up, 11% every 2 years. It's about 5.5% a year, which matches some other estimates that have been done and using other data. And part of what we're thinking is that, if you borrow after a health shock, it's not necessarily that you may be more or less likely to borrow, it's why you're borrowing and how you might use the funds. So people who are borrowing after a health shock may be more likely to allocate those funds towards health expenditures, or people who are borrowing prior to health shock may be more likely to allocate those funds for leisure or for other types of consumption. But so there is a higher rate of home sale in this group, but we saw not a significantly higher trend in borrowing among this group.
Okay, thank you, Stephanie. This next question is for Frank. No new drugs for Alzheimer's disease were approved for many years, but your estimate indicate that drug innovation reduced the number of people with cognitive limitation in 2015 by 3.2%. How is that possible?
Well, as I very briefly mentioned in my remarks, there is evidence that essentially having certain medical conditions like depression and other conditions increases the risk of having cognitive limitations. And therefore, if there are new and improved medicines for those comorbidities, that could indirectly affect the probability of having cognitive limitations. So I think it's not unreasonable to expect that to occur.
Thank you. Let's see. Another question for Eric. In your data, you can measure out-of-pocket Medicare and Medicaid spending. How important are other payers, such as private health insurance, for medical spending for the elderly?
Right. Yeah, thank you for that question. So in terms of what's paid for by largely private insurance, but also lots of other little payers such as Veterans Administration and the like, that represents about 20% of total medical expenditures amongst those ages 65 and older. So we are working on imputing those payments in as well. So we'll have a complete picture of medical spending for the 65 and older population, but we haven't done that yet.
Okay. Another question for Stephanie. Your study found that it is not holding home equity that improves health following health shocks, but borrowing from home equity. However, the rate of borrowing is very low among older adults. So what do you think, what are some of the barriers of borrowing?
Yeah, no, this is a great question. And this is something that, Perturba and others have kind of wrestled with, is why do people not decumulate their housing wealth in older age? And there's many different explanations. One is precautionary savings for a health shock. So that's part of why we were motivated to study this, because we wanted to see if that indeed was happening. Another is a bequest motive. So people may be wanting to leave their inheritance to their kids, and so they don't want to spend down their wealth because of that. But another reason is borrowing constraints, which is something we think hasn't been given enough attention. And so in older age, it could be that people actually would have a preference to borrow and can't. And so we've been trying to understand how large is that group of people, and how much is that contributing to the lack of the saving and retirement or spending from home equity? But all three of those things could contribute.
Okay, thank you. This other question for Frank. Your findings suggest the positive effect of drug innovation on reduction of benefits received, as well as increased quality of life due to reduced health limitation and medical care utilization. However, all of the improvement of these outcomes are likely to indirectly affect longevity. Can you say something more about the impact of those innovation on longevity? You hinted to that, but can you say something more?
Yes, I mean, I certainly do think that there are longevity effects and longevity benefits of innovation, and actually I studied that using the MEPS data, the Medical Expenditure Panel Survey data, in a paper that I wrote a few years ago by linking the MEPS data to mortality follow-up data, where we can actually see how long the person lived. Those data have gotten a little harder to use. Now you have to go to a research center to use the data, but those data and other data that I've studied strongly indicate that these new drugs have in fact increased longevity as well as reduced disability.
Thank you. Another question for Eric. You find that the persistent component of medical spending is extremely persistent, especially for those who already have high medical spending and receive large shocks. Why do you think this is the case?
Right. So we see a fair amount of persistence throughout the distribution, including at the top. And I think one very important medical spending issue is long-term care. And so, for example, the vast majority of all individuals who wind up in long-term care, at least for an extended period of time, wind up leaving that nursing home through death. So it seems as though that's a key risk. Nursing homes, not just that they're very expensive in a given year, but they're that those who wind up in nursing homes, they tend to stay in them.
A follow-up question, Eric, is that in your model, you do not control for race, ethnicity, or education, which are strongly correlated or related with health and consequently medical spending and mortality. Why don't you kind of control for those?
Yeah, that would be a very interesting thing to include within the model. So right now, in terms of what we have included, so we've accounted for example, marital status, for measures of lifetime income and the like, but we can certainly think about adding in additional measures in terms of race and ethnicity.
Okay. Thank you. The other question for Stephanie is that research shows that most recent cohort of older adults are carrying more mortgage debt and other loan prior to and into retirement, which is a concerning trend that is likely to hinder their ability to access their home equity. Based on your study, how might we expect this to change financial security of future cohorts of Social Security beneficiaries?
Yeah, this was actually one of the things we wanted to look at in our study. And so we wanted to see how, the rising debt levels of newer generations of baby boomers might reduce their ability to borrow in the future. And then that might affect their longer term financial well-being. So if you think about, our measure of home equity held prior to a health shock, if you're age 68 and you've borrowed at age 60 before your health shock, you may have less home equity than when you get to that point where you might need it to be able to spend it. So we know that more older adults are entering retirement with this mortgage debt. And so I think that if we do believe our results, and we do believe that that borrowing from home equity could help resolve a shock, and two, that borrowing constraints can reduce your ability to borrow from home equity. Rising LTVs among older, newer cohorts of retirees could increase constraints and could potentially reduce the ability to borrow. With that being said, in some of the simulations we've done, we don't see that the LTVs are getting to that point where they're going to prohibit them from being able to borrow. But it could, if we think about, the longer term financial well-being and the general life cycle, this could have some effect later on.
Okay, thank you. Another question for Frank. Your estimate of the value in 2015 of some of the reduction in disability, Social Security recipiency, and use of medical care attributable to previous drug innovation is fairly close to 2015 expenditures on drug classes that were first approved between 1989 and 2006. Why are the costs likely to be lower and the benefits likely to be larger than these figures that you presented?
Right. Well, I did not account for it. It's hard to say what's the value of not being cognitively impaired. I don't know if we have a good measure of that. We can attach a good dollar value. So I don't value all of the reductions in disability. Also, as I said, there's no valuation of increased longevity. And also, I recently published a paper about creative destruction in drug prices. That is, when new drugs enter the market or new classes, that tends to cause the prices of older products to decline. And so that effect is not accounted for. In fact, I estimate that about a third of the expenditure on new drugs is offset by lower prices on older drugs due to creative destruction. So that's another reason.
Okay, thank you. And this question for Eric. What are the policy implications of the results of this complicated estimation model that you have?
Right. So I think this gets back to something that Naoki brought up earlier, just that when we think about insuring against financial risk, we want to think about insurance against financial risk, not just within a given year, but over the course of one's whole life. And so what we're interested in better understanding is just how these coinsurance schemes impact medical spending in multiple years. And certainly one place that we'd like to go is to think about these different sorts of risks, such as, for example, being in a nursing home, and the fact that for many households, there's relatively uninsured, and that may last a very long period of time. And so it's for these sorts of reasons that we think that we do want to account fairly accurately for all the dynamics in terms of medical spending, and as well as to properly capture what share is actually paid for out of pocket.
Okay, thanks. And the last question from the audience is that what data sources, for Frank, this is for Frank, what data sources are you making use of? You mentioned maps, but any other data sources?
Well, the medical expenditure panel survey is where most of the data come from, but I'm also getting data to construct the innovation measures from a data set called Drug Central, which tells us when different drugs were first approved by the FDA, and a French database, which allows us to determine what the indications of each of those drugs are, what diseases is each drug used to treat. So and that's all described in detail in my paper.
Okay, thank you. I think we have addressed all the questions. Is there anything that you want to say in closing?
I
Okay.
do not.
Okay. Okay, then thank you everyone for this excellent session, your presentation and discussion. And thank you to all participants for their questions. Michael, back to you.
Thanks, Irina. Thank you all. It was a great panel. I know this is a tough time slot on a Friday afternoon, but I think there were some great, you wove together some great interactions across these papers. So thanks very much. So that brings us just about to the end of our stretched out over 2-day meeting. And so I appreciate everybody being part of each of the 6 panels and the speakers. Just a few summary comments and I'll let you all go about your weekend. So, I think the day started today hearing from Dr. Valerie Wilson and the issues of race and inequality. And these are issues of race and inequality that we've been facing as a society. So it's not just unique to the RDRC space, but I think she helped us to think about how to unpack what race means. We have race in our variables. Sometimes we put them in models, but do we really think about what they mean? And so I think while we recognize the data is not where it needs to be, we can all do more to think more about the processes that drive hardships and other outcomes. And so I think that was a great challenge for her to bring to us. I do want to emphasize that all 4 of the RDRCs are taking this challenge to heart, and we have been, for a while. We're trying to reach out to more researchers from diverse backgrounds and trying to make racial disparities more of a central theme of our work. So we thank Social Security Administration for their leadership on this, and the commissioner in particular for her leadership on these issues. Then our next panel, we started to talk about how people understand the programs and benefits of Social Security Administration. And this is a topic I've worked on for a long time. And the more we learn, the less we know, it feels like. We need to do a lot more to understand how people get information about these programs, and then what they do with that information. Do they get the information they need at the time they need it? Do they stay informed? And then, ultimately, even though we might be able to come up with technologies or new ways to get people information, we got to make sure that we don't leave some of the most vulnerable people behind. So back to my last point, trying to think a bit more about how inequities might be continued and preserved in some of these kinds of systems. Then we talked a bit about people with disabilities, especially for workers who might be eligible for SSDI benefits. It is an incredibly complex process that they face, that someone faces when they have a worker particularly has a disability, and they're trying to navigate healthcare and their diagnosis and their eligibility for any workers' comp, and then managing benefits across different programs. It's promising. We have health advances that can help people get back to work and adapt so that they can stay at work. But it still appears that even people who are able to get off SSDI are economically vulnerable. And so we need to be thinking about them as well. I'm very intrigued to learn about from our colleagues in the Netherlands and in other countries too, about focusing more on functional limitations and adaptations. And as we see new workers of cohorts of workers come through who are healthier, we have new innovations in healthcare that help people to adapt. This is going to be a more and more important issue for us to study. So I thank that group of panelists for bringing these issues together. I think there's a lot we can work on in the future. And then finally, most top of mind, the panel we just heard about healthcare and health shocks. And it just really strikes me how much advances in medicine are helping us all to live longer. We have healthier and healthier cohorts of older people, but it's not free. We have very high healthcare costs. And for some people, those costs can be chronic and can be quite high. And this is going to have implications for older people's consumption and wealth and debt. So while these advances, including things like prescription drugs, are helping people to live longer, we're going to have to think about what that means for the demographic trends of people who live longer, maybe disability free, but they also might have higher and higher healthcare costs and how that works out. So lots of issues. Of course, we talked about lots of issues yesterday too. So I won't recap that as well, but I think it raises lots of issues for researchers, for program managers, for anybody out there who's a practitioner, to think about, really the kinds of research we need and the kinds of information we need to make our programs better. So thank you all, panelists and discussants, people who asked questions from the audience. We appreciate it. Before I wrap up, I just want to mention that the website for today's event and yesterday's event will have the videos, the recordings of these sessions. We'll do a little cleanup for the breaks and those kinds of things and make sure all the slides and whatnot are posted. So you can always check those out for more information or share those with your colleagues. I want to thank all the team at NBER and also the staff here at the Center for Financial Security. They did a lot behind the scenes to prepare these panelists and to get these sessions together to make sure that it worked. And so thank you everyone for making this happen. Thanks to all the staff at SSA for their support, whether they were discussant or helped frame the agenda. We really appreciate all your help. So as we look ahead, August of 2022, we assume there will be another, probably the 24th annual RDRC meeting. We hope it's not the third annual virtual meeting. We hope that a marker of the pandemic is that we're able to get together. But regardless, we're going to be busy as the 4 RDRCs creating more and more research, sharing it in lots of different venues. So we look forward to working with all of you and sharing our work in the future. So I won't stand in the way from moving on with your weekend, but thank you for joining us. And I look forward to seeing you hopefully in person next year.